There is a big focus on patient safety internationally, and one of the most important forces behind this movement is the Institute for Healthcare Improvement, based in Boston in the US. IHI is the leading innovator in healthcare improvement worldwide. For more than 25 years, IHI have partnered with leaders and frontline clinicians around the globe to create new ways to improve healthcare. And we are very fortunate to be working with the IHI and getting their advice on how we can improve healthcare in Norway. We are also very lucky to have Maureen Bisognano here today. Maureen is a world expert on healthcare improvement, and she was the president and CEO of the IHI until the end of last year. And I'm very excited about her lecture on how we can build improvement from the ground up. So welcome, Maureen. The floor is yours.
Thank you so much, and I'm so excited to be with you all here this morning. This is my only Norwegian word, though. I'm so sorry I need to speak in English, but thank you for listening. First of all, before I start, I want to say that I am so impressed with the progress that you've already made in patient safety. Your use transparently of the global trigger tool is amazing, and I think it's energized all of you to begin to create a learning community, all of you here together, sharing what you've learned, sharing best practices, and eagerly looking to try and learn from one another. That passion and commitment to try and make care safer, I feel it. I yesterday spent the day out visiting in nursing homes and home care organizations. I visited a wonderful patient who had so many great things to say about the care he received after he suffered a stroke last May. I met with really young, enthusiastic, and innovative nurses and doctors and occupational therapists, and I came away filled with gratitude for all you're doing for the patients here. So I wanted to start this morning by saying thank you, because the work that you've already begun is so important. But we still have a long way to go. And so what I wanted to start off today with was to say that so many of you here today are going to be teaching, and so many will be learning. But I wanted to inspire you to think about curiosity. I was saying to someone yesterday that when I first started in healthcare, I used to go out and hire people because they had a high IQ, because they were smart. And then I changed and I started to hire people because they had a high EQ, because their emotional or empathy was high. And now I hire people because they have a high CQ, that's curiosity quotient. And so I will look to see how many times you run up and ask a question, because that's going to demonstrate, I think, your high curiosity quotient. The other thing I wanted to share is that I took this picture when I was in Africa. I was walking through an airport, and I saw this quote on the wall, and I thought it was so beautiful. If you want to go fast, go alone. If you want to go far, go together. And that's why I think 750 of you are in the room today saying we do need to go fast, but we have a long way to go still. We still have a lot of shared challenges around the world. The population is getting older, and I was talking to so many yesterday about what is it going to be like in 10 years. I have to say, one of the most impressive things yesterday was how many times I heard people who work with patients directly predicting what data is going to look like, predicting what the need is going to look like 5, 10, 15 years from now, and saying we've got to change in order to provide the best care. We've got to create new models. More and faster isn't going to get us there. We need to think in a totally new way. So today, this morning, I'm going to talk about you and us. I'm going to talk about examples of where people, doctors, nurses, occupational therapists, pharmacists, have changed the care that's given for patients and how that has begun to spread. So how change can happen from the bottom up. And then tomorrow, I'm going to talk about, once those models emerge, how can leaders work to spread them? So today, bottom up, all of us. Tomorrow, how do we share and spread more effectively and more quickly? And the other thing I want to push a little bit on is we're here to talk about safety, and I will talk about safety. But we also have a bigger goal. Back in 2007 at IHI, we created this idea of the triple aim. We began to travel around the world and say, we think that everybody who works in healthcare has 3 jobs. One is to improve care. That's primarily why we're here today. Make it safer. Work on access problems. Make it more patient-centered. Hear the voice of the patient. All the things we've been talking about this morning. But the second piece is we need to work upstream and help people to get healthy. We need to keep young kids healthier. And we need to work with the elderly to keep them healthy at home. We as healthcare people can't just wait until someone gets sick and then fix it. Our job also is to work on health. And thirdly, all over the world, we've got problems with cost. So in 2007, we walked around, talked to people around the world, and we said, do you see all 3 of these as your job? And nobody said yes. People said, this is me over here, I'm working on safety. Or this is me, I'm working on health. Or I'm a finance person, I'm working on cost. But what we had to do was put that black dot in the middle, that dot to say, we need to integrate. We need to bring all of these together so that we can work on the triple aim. So as we think today about the challenges that we face, we at IHI are working both on improving care, but also on improving health. And I want to give you some examples of how individuals have stepped in from the bottom up and begun to think about both care and health. The special areas of focus I want to talk about, one is on quality and safety. And you'll notice that I have these themes woven throughout my whole talk this morning. But what I'm seeing around the world is that people are, doctors and nurses are coming together and they're saying, let's work in a different way. Let's, as an example, rather than come into work in the morning and go directly to our individual patients, let's huddle. And you're going to hear some talks this morning and this afternoon about people who are developing huddles, ways to work as a collaborative team. We're looking at safety, new ways to talk with one another about predicting risk. It used to be when I was working with patients, I'd come into work in the morning and the nurses on the next shift would say, what happened last night? Or what happened today? And we spent all of our time looking back. Now, around the world, I'm finding doctors or nurses that are saying, what might go wrong in the next shift? And they're finding that they're able to predict and prevent harm and injury to patients by talking in the future tense. So we developed this leadership alliance. We got together a group of people at IHI who said, if we're going to get to the triple aim, if we're going to innovate and invent new models, we should be thinking radically. And we developed with these leaders the Leadership Alliance to work on radical redesign. I love the mission of the Leadership Alliance. Care better than we've ever seen, health better than we've ever known, and costs that we can all afford for every person every time. So this group of leaders came together and they said, if we're going to get to this incredible mission, we need to think in a radically different way. And together we created these radical redesign concepts. If I could give you one bit of homework, it would be to print off the radical redesign concepts and hang them over your desk, hang them over your workstation. And tomorrow or the next day when you're back at work and you feel frustrated, look at one of the redesign concepts, and I guarantee you it will give you energy. It will give you a way to think about a different way, an innovation, a way to do something very different, like change the balance of power or standardize what makes sense. I'm going to give you some examples, and I'm especially interested in joy in work because, as you all know, we can't give what we don't have. And if people are frustrated at work, they can't give the empathy and the safe care that we all need. So all of these redesign principles are important, but I picked out a couple this morning to give you examples of how I see people working with patients every day transforming healthcare, first for one patient, then for many, and now we're spreading these ideas globally. The first one is on this idea of creating joy in work. And this gentleman is now a friend of mine. His name is Joost de Blok, and he's an RN, a registered nurse in the Netherlands. When he started working in his career some years ago, he was a home nurse. And yesterday, I went out with home nurses. I went out with home occupational therapists, and I got to see joy in work. So Joost started as a home nurse and started visiting his patients, and he had great joy in work. Along the way, a new model emerged from the government, and they said, you know, we should be more financially efficient. We shouldn't have an RN doing a bath. We should have somebody like a technician doing a bath. So that government, in order to try and save money, began to separate all the tasks and say to Joost, when you go into a patient, you can only do what your license, at the top of your license. Well, it took all his joy away, because he was now, instead of taking complete care of a small number of patients, he was running, well, actually not running, he was riding his bike from one patient house to the other, doing a little bit. The patients hated it because they had to stay home all day long, because in the morning, one provider was going to come, and then Joost was going to come, and then somebody else was going to come. The care was so fragmented, nobody understood the patient or the family. Joost's joy was gone. So he decided to create a new way to take care of patients. He named it Buurtzorg. That means neighborhood care. He left his job and he got a small team. He said, let's get a small team and we'll come together and we'll take care of patients as a team. These teams function autonomously. From 2006, he had 3 friends, and they sat in a neighborhood. They came together for breakfast every morning, and they talked, and they gathered at the end of the day. They found that the patients loved this new model. So Joost, in 2006, had 4 people working for him. Today, he's got 8,000 people working for him, 8,000 people taking care of patients in teams. And it's built on trust. These teams know how to take care of the patient, so there aren't supervisors breaking up the work. The outcomes are better care, better clinical results, the highest satisfaction rates of any patients. And look at this, the average costs are 40% below the rest of the country. The Netherlands could save 2 billion euros if they can just get the rest of the country onto Joost's model. So here's a nurse who said, I'm not happy at work. I'm going to create a new model. And this model is now spreading worldwide. It gave me so much inspiration that I went to visit him in the Netherlands. I'm 5'3", and everybody in the Netherlands is like 6'10". I don't fit in, I will say. And they said, you want to come on home visits, you have to get on a bike. And so I got on these big, heavy bikes and rode over the bricks in the red light district in Amsterdam, and it was not a pretty sight. I'll just tell you, I needed care at the end of the home visits. But what I saw was incredible. I saw joy in work. I saw better care. I saw looking at health outcomes upstream, like does the patient have an adequate food supply in the refrigerator? And I saw lower costs. So this is an example of how one person can make a huge difference. There's also some great examples emerging in mental health. And I'll give you another bit of homework, and that is to go online and download the YouTube video on the Recovery College tonight. It's a very short video. But assuming abundance means that we move away from this feeling of scarcity, that we don't have enough, and think about all the assets that you have. When we first at IHI go into work with a community or a hospital or a clinic, we'll often hear, we don't have enough this, we don't have this. And so we'll sit down and make a map. We call it a deficit map. And it's a map that lays out all the challenges and the deficits that the clinicians see. But then we make an asset map. And you can see people's faces light up when they start to count everybody as an asset. In the Recovery College, what you'll see is patients in England who have serious mental illness, schizophrenia, bipolar disease, depression. And the patients become the teachers in the Recovery College. The patients will sit with other patients who have the same disease, the same problems, the same challenges, and they'll say, this is how I overcame it. And you'll see them sitting sort of in a classroom, and the patients who are more recovered will talk to the ones who are just exploring what their world might look like. The most effective care is, interestingly, beginning to come from other patients. And so when you assume abundance and you don't think, I don't have enough time to sit with this young person with depression, and you start to look at all the resources, what you'll find is better care at a lower cost. And changing the balance of power. Some of you might remember me at a past meeting talking about an experience that I had when I was in Jönköping in Sweden, and I was making my rounds through a hospital, and I came to a unit that looked very unfamiliar. And as you can tell, I'm in hospitals every single week around the world. And I kept saying, what is this place? And they said, this is the patient self-dialysis wing. And so I said, what do you mean? The patients, I know patients do their own hemodialysis, and I know patients do their own peritoneal dialysis. And many of them, clinicians are trying to get the patients to do it at home. But I said, what do you mean? You have a wing where the patients let themselves in with an electronic card key, and they take care of themselves, and then they go home. And I said, how did this happen? And they said, oh, we've been working with IHI for many years. We're very innovative. And I said, no. No CEO I know, especially at an academic medical center, says, I think I'll build a wing where the patients take care of themselves. That wouldn't happen. So I kept asking questions until I found the person who started all this. He's a young man named Christian Farman, and Christian was a mechanic at Saab Avionics until he came down with glomerulonephritis when he was in his early 20s and ended up on dialysis. As he began his treatment, he's a mechanic. So after just a few days of his taking care of, the nurses taking care of him, he one day said to the nurse, can you teach me how to do this dialysis? I'm a mechanic, I think I can do it. And so he learned how to do it, and then he taught the 73-year-old lady in the next bed how to do it. And then pretty soon, 75% of the patients in the academic medical center 70% are doing their own dialysis now at the unit. So I spent several days with Christian. And what I said to him is, first of all, where did you find the courage to say to the nurse, I want to take this myself? And he described how, he said, I've done a lot of research into the disease. He said, I know that I won't have a good life. And I said to him that day, what matters to you, Christian? And he said, I want to work. And so he, with the nurse, began to do his own dialysis. And I started to ask him what mattered. He said, I want a full life. I want to be able to work. He said, I'm now consumed with my disease. I spend my whole day calling for appointments for my dialysis, coming in. He said, sometimes I'm under-dialyzed, and he taught me about post-dialysis syndrome. He said, then I have to go home and get into bed and sleep until, he said, my life is so incomplete. And so I said to him, but what about safety? And this surprised me. He said, well, of course the care is safer in my hands. I thought he was going to say, well, there's always a nurse somewhere I can find, or I have my cell phone, I can call for help. But he said, of course the care is safer in my hands. He said, first of all, I always do it the same way. And every single nurse that comes in has their own technique, and that variation scares me. And second, he said, it's my bacteria, not yours, so I'm not going to get infected. And he's right. As they started to teach other patients, the complication rates dropped. So I went to Annette, the nurse leader, and I said to her two things. One, how did you figure out how to design a unit, a separate unit, where the patients all take care of themselves? And she said, as more and more patients began to do their own treatment, she said, I went to the CEO of the hospital, so Plan, Do, Study, Act cycle with Christian, with the 73-year-old lady, with the nurse manager, up to the CEO. And she said, I can't achieve economies of scale if I have patients mixed in of different severities. She said, plus some nurses and doctors love it on the acute unit, and some love it on the independent unit. And she said, so there's not really that much joy in work, but if I can separate things, I think I can get to the triple aim. And so he said, okay, and they built this unit. She was designing the unit one day when she heard a knock on the door, and it was Christian. And he said, what are you doing? And she said, I'm designing the unit. And he said, what will it look like? And she said, oh, I want it to be home-like. Low lighting, comfortable chairs, we'll have a little music in the background. It'll be like home. And he said, it's a hospital, goddammit. We don't want it to look like home. And so he said, I want it to look very different. And I'll show you in a minute what it looks like. My second question to Annette is, what's your job if you're not taking care of patients clinically? And she said, I looked out one day and I said, if I'm going to work on the triple aim, I should know, I should care about what these people, what matters to them. So she went and asked all the patients, what matters to you? And they said, we want to work. So now, every patient that gets admitted to this dialysis unit, the first thing she does, the head nurse, is she sits with them and updates their CV. And she says, I track success by knowing how many people are working. Now, your homework, when you go back, is pop up into the dialysis unit and see how many people are working. See what that unit looks like. I've been in dialysis units from Vancouver to New Zealand, and it's clinical. It's not about what matters to them. But when you go in this unit, it's completely different because of Annette, and this is what the unit looks like. He said, I don't want comfortable chairs, I want exercise equipment. And every patient in that unit, they let themselves in with an electronic card key. They make the coffee for the nurses because they're in there early in the morning or anytime they want. They make their own appointments. They come in whenever they want. They do their procedures. They clean up. I said, why do you feel like you have to clean up after you do your treatment? They said, we clean up much better than the staff. And they exercise. Look at this gentleman, how this elderly man is exercising while he's dialyzing. But they either come in an hour before or they exercise while they're dialyzing. And the results are dramatic. Costs are much lower. Infections and all kinds of complications are lower. And they're measuring by the number of patients working. So I said to Christian, when I went back the next year, did you go back to Saab? And he said, no. He said, I'm an RN. He said, I decided I'm in the hospital all the time anyway, so I went to nursing school. And today, Christian is the head nurse on an ENT unit in the academic medical center. So the next year I said to him, so what matters to you this year, Christian? And he said, I want to get married. He went from feeling like a depressed, chronic patient to saying, I want to get married. He said, I'm young and I'm vital now. And I got invited to Christian's wedding. And then the next year I said to him, Christian, what matters to you? And he said, I want to have a baby. And here's his little baby, Wilmer. And this is just an example of how one person saying what matters to you has made such a difference, not only in this hospital and these patients' lives, but Christian and Annette recently went to Texas in the United States. And Christian, the patient, and Annette, the head nurse on this unit, are now teaching doctors in Texas how to do patient self-dialysis. And the results are dramatic. So it's an example of how one person with CQ and one clinician with CQ curiosity quotient, can come together and make lives so much better for the patients in front of them and then spreading around the world. Another example is one of the design principles is customizing to the individual. And you've heard me say so many times already this morning that we need to move, as Susan Edgman-Levitan says, from saying, what's the matter with you, and then just jumping in to fix what's the matter, to really thinking in a totally different way about what matters to you. And I was teaching in Paris some years ago. There was a nurse sitting in the middle of the audience. Her name was Jen Rogers, and she worked at a pediatric hospital, still does, in Scotland. And she went back and said, I have to try this. So she started getting a piece of construction paper for the next patient who got a first name and your age, and write what matters to you. And she started doing this with one patient and then many, and now every patient in that hospital on their door has a poster that says what matters to you. I brought you one example from Kendra. She's 7. She's severely autistic. She's never spoken. She says hello to the staff when they come into her room by pulling their hair. And her father made this map for her. It says, I don't like medication by my mouth. I will fight. I will struggle. It's a 3-person job. I'm very fast, and I'll put things in my mouth, and I'll run. She says, I love cuddles to reassure me. I can high five. I can dress myself with some help. The night Kendra was admitted to the hospital, her father, who's her only caregiver, collapsed, and he was taken by ambulance to the adult hospital on the other side of town. Kendra was all by herself, and the doctors and nurses said, we know exactly how to take care of her because this map is on the wall. So that idea spread from the pediatric hospital to many other hospitals. Not a week goes by that I don't get a map from somewhere in the world in some different language that all started with Jen Rogers saying, I think I'll put a map up on the door. One other example is a woman named Barbara, a 78-year-old lady admitted to a hospital after falling at home. And the nurses and the doctors were talking about getting her on antidepressants and putting her in a nursing home because she lived by herself. A nurse walked in and said, what matters to you? Tell me about your life. And she started saying, well, I lived in Rio de Janeiro for 42 years. I speak fluent Portuguese. I flew planes in World War II for the WAF. And that stopped all the conversation. And she was awarded an MBE by the Queen. I can tell you that nobody walked by that sign and saw Barbara as an elderly lady who was depressed and needed to go to a nursing home. Everybody went in and said, tell me about flying planes in World War II. What was it like to meet the Queen? And all of a sudden, this woman totally turned around, and she's at home by herself, taking care of herself independently now. So what we're seeing yesterday was the huddle boards in Norway. Stefan Jura, where are you? Stick your hand up. Oh, over here. Has got these boards up all over the nursing home in Sloven. And it was just so exciting to go in and see patients and doctors and nurses, not patients, residents, doctors and nurses, talking about their lives, and it makes all the difference in the world. It's a simple thing that started with one nurse and is now changing healthcare around the world. And there's another simple thing that one doctor did. He's a friend of mine, a physician, who cares for patients at the end of life. And he decided that he should talk in a different way to patients about what matters to them at the end of life. And he decided to do it this way, to ask this question, what makes a good day? I'm going to show you a very brief video that describes him doing this with one patient.
Doctors and hospitals really aren't what we call conversation ready, because we ourselves have so medicalized everything that I'm seeing for this patient. What's the dose of this medicine? What's the chemotherapy or not? With this test or not? That we ourselves don't actually often have the experience, the practice, the support that we need to sit down with a patient as a human being, understand what's important to them as a human being, and make sure that that's always at the center of every medical plan. I was asked to see Thelma Patello. All that I knew was she was a 92-year-old woman who had severe vascular circulation problems in her leg, causing her lots of problems, for which there wasn't going to be any effective treatment that they could offer except amputation, but she just refused. She wasn't going to have that done. And so they said she didn't have that long to live, and so they wanted me to come by and maybe talk to her about hospice kind of options.
What I remember, I guess, most strikingly was that Dr. Farrow asked her, what would be a good day for you?
And so I sat down on the bed, and I said, getting to know you some as a person will help me figure out how I can best help you.
And it's such a simple question, what would be a good day for you? What do you like to do? These things that I don't feel like I have time, honestly, on a daily basis when I'm seeing patients, when I'm on call, to ask these little things.
In whatever time there is ahead for you, how can we make that as good as it possibly can be for you? Singing is what made it a good day.
But it didn't take that long to find out that this is what was important to her.
I said, when was the last time that you sang? And she just sort of said, I haven't sung in a long time. I don't sing anymore. I said, why not? And she kind of looked at me and I said, how about singing me a song?
I see trees of green, red roses too. I see them bloom for me and for you. And I say to myself, what do you say, darling? What a wonderful world. Somebody, where's the drummer?
I see skies of blue.
I see skies of blue.
Clouds of white.
Clouds of white.
The bright, blessed
The bright,
days.
blessed sun. And the dark, sacred night. And I think to myself, what a wonderful world. And I think to myself, what a wonderful world. Pop, 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 pop. Oh, yeah.
And it made such a huge difference in her day.
The music was right there as vividly as it had ever been. And every time her voice started to sing, you could just see her eyes getting younger, her face getting younger, and a kind of human joy returning.
So when you go to take care of your next patient and you're standing at the door, are you going to think this is a 92-year-old lady with severe leg ulcers, or are you going to think this is the coolest lady in the whole world? Because when you know what matters to Dolly or to Thelma, you have a totally different perspective on her. She really was the coolest lady in the world. When we were talking with her about her life, she was describing a fight she had with her husband because he had an affair with Marilyn Monroe. And yet, when she was admitted to the hospital at first, she was a 92-year-old. And so I think this idea of reaching out and asking what matters to you is making all the difference in our personal relationships. And it all started with one nurse sitting in an audience just like you are today. And I'll end with coming over to the other side and telling you a story about how one school teacher is changing health. And that's a story from Scotland. One of our projects in Scotland is working to try and create 100 million healthier lives around the world. And Scotland's joined in that project to help us to think about how do we go upstream and work on health. One of the people sitting in that project was a school teacher. Her name is Elaine Wiley. And she was telling this story so that she can spread this to all countries so that we can really change the way that we care, we think about health in young kids up to 5 years old. So these partners have come together, and Elaine was sitting in her school one day and meeting with this elderly gentleman. He's an earl from Scotland. He has his own castle, but a couple of days a week, he comes down from the castle to this little school, and he teaches the kids poetry and music. And one day he was sitting there in the classroom and he said, "Hey, Elaine, these kids are fat." And she looked at him and said, "You know, that's not my job. I'm the school teacher." And he kept saying, "These kids are fat." But she knew improvement science. So she said, "I wonder if I can run a PDSA test, a Plan, Do, Study, Act test." So she got a couple of kids, and she said, "Let's go out at lunchtime and run around the school." And she found, I had to get this translated, that they couldn't run the length of themselves. That's not an American phrase. But they really couldn't run the length of themselves. So she knew that the PDSA failed. She said that they were not fit at all. And she looked at the number of them that were fat. So she started thinking about improvement science and started thinking, I'm going to run PDSA cycles. She began, and she has her own map on the walls of the school with a couple of kids, and she developed a measurement system so that she decided, I want to get every kid to run a daily mile. If I can get every kid to run 1 mile each day, then I think that I can get them to be much more fit. She said, this is pretty easy to do when you think about it. It doesn't cost anything. It takes 15 minutes a day. The school teacher can fit it in whenever he or she wants to. It requires no training, and it's free. So you can't ask for a better PDSA cycle than that. She figured out that if each kid ran around the school 5 times, that would be a mile. And so every kid devised their own measurement system. This little girl has 5 blocks, and each time she runs around the school, she adds a block. But every kid's got their own way to measure, so the kids are learning improvement science as well as the teachers. The impact has been incredible, not only on fitness, but on readiness to learn. You can look in there, 420 students in this school. There's not one overweight kid, not one child who isn't fit. And I can't believe that in healthcare we could have a similar result. But here, partnering healthcare, teaching schools, we're seeing fitness not only for this 420 kids, but we've bought them 70 years of future good health as well. This really is, I think, the triple aim of healthcare. Not one overweight kid. The kids are more resilient. The kids are sleeping better. The parents say that not only are they sleeping better, they're eating better. And what's so interesting is, as it always happens, the kids are now putting pressure on the parents and making them have walking clubs. So now, not only are the kids fit, but the parents are out doing walking clubs. The whole town is fit because of these kids putting pressure on their parents. They're eating better, they're sleeping better. And the feedback from the teachers is that the kids have so much more attention, that they said that kids who were in trouble before, who would never walk up to the front of the class in front of all their peers and say to the teacher, I need help, they're in a totally different place now. And what they'll do is they'll just run alongside the teacher doing the daily mile. So the kids who are in trouble are getting the best attention that they can. All the kids are resilient, and all the kids are more focused. So the outcome is improvement science and a focus on health. With school teachers, we're going to find that we've got to reach outside of our clinical expertise in order to produce better health. That we're going to find all kinds of different partners. You probably have read the story about Jersey in England, where the new caregivers are, do you know? The mailmen. The mailmen visit these elderly housing projects every day. They go to these people who are living alone, and they're socially isolated. And these people are depressed, and yet the one common thing that they have every day is the mailman is visiting their house. So they trained the mailmen 3 times a week to knock on the door. They don't go in, but they just have a 5 or 10 minute interaction with the elderly person in the home right at the doorstep, and it's changing everything. Not only are the elderly people saying, my prescription didn't come, or I ran out of food and I have no way to get to the store, and the mailmen have methods for intervening, but the mailmen are saying that they are finding joy in work that they never, ever found before. So I think we've got to increase our CQ, reach outside ourselves, and say, what are all the assets in the community that we can bring to bear to get to the triple aim. So your challenge from me today is do your homework tonight. Be thinking always that you've got two jobs. You've got your job of being a pharmacist or a nurse on an OB unit or a rheumatologist, but you've got this other job. And I would say to you, the challenge is to build your improvement skills, to maybe go to the IHI Open School or take a course or learn from someone in your hospital. How can I run the same PDSA cycles that Elaine ran in the school? How can I think about my other job, my job of improvement? And build those improvement skills every single day. I would say learn to see. When you're walking through the halls, if you see a patient that looks like they're in distress, my request to you is don't walk by. Don't walk by. If you stop and you find out what is it that's challenging for this patient or this family or this colleague, your own staff member, don't walk by. That question that you ask will give you deep insight into the kinds of things that you'll want to improve when you've got your skills. You can make, independently, a huge difference for your own patients. And together, we can make a huge difference, not only for all the patients in Norway, but we can then spread this around the world. So I would say, as Margaret Mead has told us many times, never doubt that a group of thoughtful, committed citizens, that's us, can change the world. Indeed, it's the only thing that ever has. Mange tak.
Maureen, thank you so much. It's so exciting to listen to you, and you have so valuable perspective, and you always have new ideas. It's very exciting, and I'm looking so forward to hearing you tomorrow at your second keynote speak at the plenary tomorrow afternoon. So thank you again so much. As a token, a symbolic token of our appreciation, you're also going to get the donation to the Norwegian Refugee Council, who works with children in crisis in Syria. So thank you very much. Vær så god. Brilliant.